nerve anatomy. I'll have to keep you awake for this one, but there is some important stuff in here. So, dermatomal distribution. You have to memorize this. If you want to do spine work, you have to know this. Now, do you have to know that S1 starts near the rectum and radiates all the way down to the lateral aspect of the foot? Well, it helps. If somebody's got an L5-S1 herniation and the pain radiates to the bottom of the foot, that goes, hey, that could be an S1. If the pain doesn't go below the ankle, is it going to be an S1? Maybe. We'll talk about the centralization phenomenon. But what happens is that if the pain is in the foot, can you rule out maybe an L3? The answer is probably yes, right? Because L3 doesn't go down to the foot. So this is the quick and dirty. You'll find it in the book, so you don't have to copy these down. So S1, lateral foot, L5 right over the great toe, L4 medial calf, L3 at and above the medial knee, 2 in the thigh, 1 in the groin. Just remember that, and if you remember that, it won't be an issue, and then life gets easier. The other thing you have to remember are the muscle innervations. You got to remember them, and they have to be rote, just like your dermatomes. So the primary rami, for the posterior muscles of the spine, they're all innervated by everything. But here's the gastroc soleus. Don't worry about S2, but it's almost always S1. So if you've got a weak gastroc soleus calf muscle, is it going to be an L5 root? No. But if you have an extensor hallucis longus, is it going to be an S1 root? No. So you already have a differential right there. But then somebody comes in with drop foot, and you've got a problem because there's 2 roots that can involve here. So if somebody comes in with a weak EHL and a weak tibialis anterior, what root do you think it's going to be? L5, right? But if they come in with a weak tibialis anterior and no EHL weakness, more likely than not, it's an L4. It's a nice little differential. So, spinal motor nerve anatomy. Everybody knows this from physiology in high school and college. The dendrites accept the signal. It's transmitted down the axon to the terminal butanelles, where you have some kind of neurotransmitter that transmits the signal to the next nerve. And everybody remembers myelination, where you have these fatty cells, either the oligodendrocytes in the CSF or in the peripheral nerves, the Schwann cells. And these wrap around the nerves and create saltatory conduction. So the signal skips from one to the other, increases conduction time by 10 to 20%. 10 to 20 times. Huge increase. But what's the weakness in this kind of thing? Well, if there is an injury to the cells that wrap the nerve, but no injury to the nerve itself, what happens? You get conduction block, even though the nerve is still there. So this is a little bit more than maybe we need. There's 4 groups of nerves. The alpha is motor, proprioception, sensory, and reflex. Betas are muscle innervation, touch, and pressure. Gammas are muscle spindles, which are the little tiny mechanisms in the muscle to tell stretch and activity of strength. Delta fibers, pain, and temperature. But basically there are myelinated, partially myelinated, and non-myelinated fibers that conduct at slower and faster speeds. Pain nerves are this, and most of the somatic nerves are this. So neurologic anatomy, this is important too for local injury, because that's what we're talking about here. Do they have a fracture? Do they have some kind of herniation? Do they have a collapse where something's compressed? So where do all these nerves originate? Well, if you look at the S1 nerve, which comes out of the sacrum, and we follow it all the way back, it originates at T11-12. So can you have a T11-12 injury causing problems to S1? Yes. And where does the spinal cord end? It ends at the conus behind the body of L1. So can you have an L1-2 injury and have a spinal cord injury? Yes. Okay, parasympathetic, sympathetic supply. We all remember this, but we'll go over it again. The sympathetic supply comes from T1 through T12. and then it spreads throughout the body. Remember Horner syndrome, where you get a drop face, right? Lack of sweating, anhydronia. Help me out, Eric. Meiosis, ptosis. And so that's because the sympathetic nerve goes up the neck into the face. So if you have an injury in the thoracic spine, you can have a problem in the sympathetic nerve in the face. Well, the same thing occurs with parasympathetics that come out at S2, 3, and 4. Do you remember the famous mnemonic? S2, 3, and 4 keeps your poop off the floor. You'll never forget it now. But nonetheless, that's because you have S2, 3, and 4 nervi erigantes functioning for bowel and bladder. And that comes into play when we're talking about problems with bowel and bladder function. So nervi erigantes is the outflow of the conus at the end of the cauda equina. So if you follow the conus at L1 it ends, the very tip is the nervi erigantes from S2 to 4. It's involved in cauda equina syndrome, which we'll talk about, and damage to only the conus will cause bowel and bladder malfunction without leg impairment. We just had a patient just the other day who had an L1 burst, was fixed, and the only problem is he has to digitally stimulate and occasionally cath because he injured the parasympathetic outflow of the cord. So the skin sensors, maybe more than we need, but I thought I'd put them in there. So nociceptors are generally free nerve endings. Meissner's corpuscles are for touch, so you can see how it's designed. Pacinian corpuscles have a greater envelope than these, so it's more for pressure. And then you have thermoreceptors. So why do we have pain in the back? Well, it's because the annulus is imbued with pain receptors. Nociceptors, of course, are the pain receptors, and they're originating from the outside and inside. Outside is the sinovertebral nerve. On the inside, we think is the basivertebral nerve, which comes through the basivertebral vein outflow. So tears in the annulus will develop angioneogenesis and neuroneogenesis, and there's ingrowth of new nociceptors accompanying new vessels. So you get a tear, there's not a lot of healing, but the healing that does occur is a problem because you have ingrowth of new pain fibers. So we're sort of screwed the way we're designed. As we get tears, we increase our pain sensitivity, but not everybody. So other people will say, well, does bone cause pain? Bone is hugely imbued with nerve fibers within the Haversian canals, and they thought to be transmitted through the basivertebral vein and penetrating arterioles in the anterolateral body. So their bone is highly innervated and quite painful. This is important because we're going to talk a little bit later about peripheral neuropathy. So all of the nerves are vascularized by arterioles and venules, and these create a functional milieu so the nerve can conduct. You've got ATP going on, you've got sodium-potassium pumps, you've got calcium channels. All these things require energy. And all these energy, it comes from ATP, from delivery of glucose along the blood vessel. So what happens if you start to infarct these blood vessels? What happens to the nerve? What happens? It starts to malfunction. It doesn't necessarily die, but it malfunctions. So people who come into your office with peripheral neuropathy are having slow loss of these arterioles and venules, and they start to develop symptoms because the nerve is not functioning right. So what is it about the spine that makes the nerve more vulnerable? And it is more vulnerable in the spine. That is because, well, here's the cord, and then you have a nerve coming out from the front and the back. Do you guys remember what's front and back? It's right there. Actually, the motor nerve is in the front, sensory is in the back, but that's okay. So the sensory nerve and motor nerve join into the radicular nerve here, and this nerve before the dorsal root ganglion is not armored. After the dorsal root ganglion, the nerve is armored with epineurium, perineurium, and it is hard to hurt a nerve. But before the nerve turns into that, right past the dorsal root ganglion, the nerve is free. And that happens to be, unfortunately, where disc herniations occur. So the disc herniation takes a more vulnerable problem with a more common disorder and creates issues. So reflex arc, this is important. We'll talk about for certain neural diseases. But the reflex arc is very simple. You have a tendon and you bang your hammer on the tendon and it sends a signal into the cord. There's an internuncial nerve and then it continues directly into the muscle. And so you get, of course, a contraction response. Well, why do people have contraction responses that are greater with hyperreflexia? What happens with myelopathy? There's no inhibition. So this nerve, this internuncial nerve, is a brake. It slows things down. So if you have an injury to the cord, you lose that brake, and that's why you get hyperreflexia and clonus and things like that. So it all makes sense. This is the action potential. Everybody remembers that you have conduction wave, sodium flows in, potassium flows out. You change the polarization of the root, and it continues all the way down to the end. And at the end, what happens is you get calcium that binds in. There are calcium channels here, and when the wave comes down here, it opens the calcium channels. Calcium binds with the neurotransmitter vesicles. These vesicles then bind with the end of the nerve, and they disgorge their neurotransmitters that go then to the next one. So that's the synapse. And that is affected by certain disease processes too. And again, this is just another way you can see it. The voltage-gated calcium channels, calcium flows in, binds with the vesicles. These then bind with the membrane, and they conduct their chemical warfare, so to speak. But this occurs instantaneously. It's amazingly quick. And this is the reason why. Somebody was kind enough to make us an acetylcholine receptor. So this is a big pore, as you can see, that sticks right through the nerve membrane. When acetylcholine, a very small chemical, latches on, it changes the morphology of this and opens up a hole. And because there's high calcium ions on one side and none on the other, calcium flows through the hole down that gradient and then starts the process rolling. Then the acetylcholine actually, if you guys remember Brownian motion from years ago, the acetylcholine just sort of bounces out and is taken care of by acetylcholine receptors. So there are enzymes that create transmitter. This is next thing, we have to talk about peripheral neuropathy. Why is peripheral neuropathy a big deal? Well, everybody remembers from high school biology, the cell nucleus creates the proteins. Think of proteins like foldable, what's the best way? IKEA, where you put things, you get it in a box, and it automatically, you hope, folds together and puts together. And then this protein needs to be transported down the cell, right? Because the nucleus is next to the dendrite, and then you have a long axon, and then you have all those neurotransmitters at the end of the axon, right? How does that get down there? From axonal transport. Speed of transport is 0.5 to 5 millimeters a day. How long is a nerve that goes from the spine at L5 into the tibialis anterior? It's 18 to 20 inches, right? So how long is it going to take to get down there? It's huge. You have to have this axonal transport functioning all the time, every day, every moment. If you have a vascular problem to the nerve and you can't transport these things down, which take ATP, you're going to have a block. And what's going to happen after years? What's the disorder that everybody knows in this room? Peripheral neuropathy. This is what causes peripheral neuropathy. And it's very common. I think we see it in 5 to 7% of our patients that come into the office if you know the questions to ask for. Okay. So then we have to talk about the neurochemical transmitters. Glutamate, most common neurotransmitter. Everybody's heard glutamate or GABA, right? Gamma-aminobutyric acid. It's the excitatory transmitter, and it's interestingly exactly the same as MSG. So when you go to your Chinese restaurant, you're sprinkling neurotransmitter on your food if you do that, just to let you know. So gamma-aminobutyric acid is the analog of glutamate, and that is an inhibitory neurotransmitter. So everybody knows Neurontin or gabapentin. So what you're taking is an inhibitory chemical to slow nerves down. That's what it is. Dopamine plays a key role in the functioning of the limbic or emotional system, emotional function and control. Dopamine also plays a part in movement, alertness, and sensations of pleasure. So dopamine is considered to be one of the problems associated with narcotics. Some people get release of dopamine, others don't, which is an interesting fact because even though the narcotic craze and the malfunction today is from that, there are many patients that can take a narcotic and not have a euphoric response. And those are patients that might be suited to mild chronic narcotic usage. We have patients probably, every week we'll see one or two that's been on Vicodin 1 to 2 per day for 10 years and doing just great. They don't have tachyphylaxis, they don't have the other problems. We'll talk about that again. Serotonin plays a regulatory role in mood, sleep, and other disorders, and that is affected by SSRIs. Everybody knows Prozac, right? But that's what it does. Prozac increases serotonin, and of course acetylcholine incorporates motor function and memory. So this is the hard part. This is a lot of droning information, but still stick with me. So each motor neuron can innervate from 1 to 25,000 muscle fibers, either very fine skills like fingers in your hand to very coarse like quad or gastroc soleus. So one muscle fiber receives inputs from only one motor neuron unless there's budding, which we'll talk about for injury. On the muscle side of the junction, the muscle fiber is folded into grooves, and the space between the grooves contains the enzyme acetylcholinesterase. So you saw that picture of that pore, right, with the acetylcholine right there. There are tons and tons of those in the muscle spindle end plate. And there's acetylcholinesterase, which destroys acetylcholine, because if you don't destroy it, what disease process do you have? What? Go ahead, don't be shy.
If the acetylcholinesterase is destroyed.
It is not destroyed. Yes, myasthenia gravis. If you don't have acetylcholinesterase that's working well, you're going to have contraction, right? Oh, whoops, sorry. Okay. Nerve gases thwart this breakdown, so they create prolonged stimulation over the receptor cells and severe muscle contractions. And so that's why people get physostigmine and other injections that if you have nerve gases, that's typically how they occur. And the paralytic agent curare acts by blocking transmission at the synapse. So curare looks like acetylcholine and binds to the receptor, which is why you become paralyzed. So, again, here we go again, more technical things. Nerves have a resting potential of negative 70 millivolts. To fire the nerve requires 55 negative millivolts. And if you have the opening of the ion channels and you get a net gain of positive charge, the membrane is depolarized and it's called an excitatory. And if you're hyperpolarized, it's harder to move the membrane. So again, we'll go through this. The strength of a synapse is defined by the charge in the transmembrane potential. Changes in the synaptic strength can be short-term without permanent structural changes or long-term. So the actual synapse can change physiologically to make the nerve easier to conduct the next time or more problematic, harder to create another voltage. Easier means obviously the nerve's going to trigger with less potential, called facilitation, which is a problem with chronic pain because once you continue a pathway, it seems to be easier the next time. And with chronic pain, you can develop a reverberating circuit. That's one of the issues with chronic pain. Okay, so that's just more than we need here. Let's talk about ectopic foci. So if you have a doorbell and you hear the doorbell go off and you go to the front door and there's nobody there, you say, I don't know what happened there, and then you check the doorbell, it's functioning normally. You walk away and it goes off again. What's going on? Generally, what's happening to the doorbell? You have a short in the system. The doorbell is going off even though you don't have anybody pressing the button. This is ectopic foci. If you have an injury to the membrane of the nerve is going to trigger even though the receptor connected to that nerve is not talking, so to speak. Right? Make sense? This is what happens with nerve injury. So chronic nerve injury, what we call chronic radiculopathy, is an injury to the nerve membrane where the signal is transmitted to the brain even though the connection to it isn't transmitting. So, for example, foot pain due to an L4-5 herniated disc. The foot is miserably painful. People want to cut their legs off. But where is the disorder? It's in the spine. It has nothing to do with the foot. But because that nerve is activated by the herniation, the pain is coming from the foot, even though we know the source is in the lumbar spine. This is sort of a loose form of an ectopic focus. And this is one of our bugaboos. How do we treat these? This is something we don't have a good answer to. Stretch injury. If a nerve is stretched, it may simply recoil to its original length when the force is relieved. The nerve may completely snap, similar to the stretch and snap of a rubber band. And in general, a nerve can stretch about 6% of its length without injury. A stretch of more than 15% will cause, will cause irreversible damage. It's important in the leg, it's more important in the arm for people with brachial plexus injuries. But there's no way to predict how far that nerve is stretched, so you have to wait for recovery. Muscle weakness. So muscle weakness is caused by the lack of the muscle cells in one muscle group receiving a signal. So if you've got a weak biceps, or you've got a weak gastroc soleus, or you've got a weak tibialis anterior and foot drop, but it's still functioning, the nerve is still in continuity, but not all of the nerve fibers are transmitting. So a nerve is like a big transatlantic cable. You've got hundreds of thousands of nerve cells in that nerve, and if some of them are malfunctioning, the nerve will not transmit those signals to the muscle, so maybe 70-80% of the muscle fibers contract, but not all of them. That's what's going to cause muscle weakness. What happens if you fully transect the nerve? Muscle's flaccid. Ask them to contract, there's nothing there. It's a 0/10. Everybody knows the grading system for muscles? 0 to 5? Okay. So if you have a flaccid muscle, that means that possibly the entire nerve is malfunctioning. However, what happens if you check the dermatome on it? What if the dermatome is normal? So you have a specific injury to the muscle side, but not to the sensory side. That's important. So functional compression. This is how specific nerves can get injured. And you all know this. You lay your arm on the table or on a bar. And what happens in about 5 minutes if you're not thinking about it? Your hand goes numb, right? And if you lay it there long enough, the motor function stops. You've created a conduction block, a functional conduction block. And when you take the arm off, it recovers. Except if you have Saturday night palsy. Does everybody know what that is? So if the arm is, if you're drunk, right, and the arm's sitting there for hours, you can actually kill the nerve. But most people who are conscious won't do that. And so this is important because it's a functional block. Oops, sorry about that. It's a functional block, and I think I've lost my laser. There it is. So this is the same physiology noted with dynamic nerve compression, such as foraminal stenosis or neurogenic claudication. So remember, the patient stands up and walks and their buttocks and legs start to go numb, and what do? Yeah, they bend forward. Why? They're opening up the spinal canal. It's the same exact thing, whether it's in the spine or it's in the arm. This is a functional block. So there is a conduction block that's called functional, but it's really organic. It's a myelin sheath injury. You remember saltatory conduction. If 1 or 2 or 3 of these cells dies, then you have an issue because the signal won't conduct down the nerve. There's a block, but this will recover. The nerve cells that bind around the oligodendrocytes and the Schwann cells will re-heal. So how long does that take? Oh, sorry about that. How long does that take? If I can find my area, here we go. So repair of this sheath requires between 4 to 12 weeks. So it's important to know what you're dealing with. Will end up with a situation where you're not going to know until it recovers or doesn't recover. But this is what you're dealing with. If you have only a myelin sheath injury, this requires between 4 to 12 weeks to recover. So what do you have with Wallerian degeneration, regeneration? Everybody remembers the inch a month, the nerve heals, right? That's what we're dealing with here. That is a specific and not typical injury where the nerve itself is cut, but the myelin sheath remains. So if the nerve is cut, but the myelin sheath remains, that nerve wants to go back down and connect to its source. And that's Wallerian regeneration. And that's the inch a month. What's the problem with it? Well, the problem is, oh my goodness, the muscle without a nerve supply will become fibrotic in a period of 12 to 18 months. Muscles that are 18 inches or less from the nerve injury still might regain function. But if it's 18 inches or more, the muscle's going to become fibrotic. And so even though there's a chance that nerve can heal all the way down to the gastroc soleus, if you have an S1 nerve compression, which is way up here, and the gastroc soleus is 2 feet away, is that muscle going to recover if you have this injury? No. But if you're, let's say, in L5, going to the tibialis anterior, it's about the same distance, so that nerve won't recover, the tibialis anterior won't recover, but the gluteus medius, which is an L5 nerve, is close. It's about 8 inches away. So that will recover. So some muscles in the same nerve group can recover and other muscles can't. And a complete nerve injury, so you either have a stretch injury or a sever or the nerve is dead. This is found with more prolonged stretch or severe compression. The nerve itself, along with the myelin sheath, dies. This nerve cannot regenerate, and the muscle cell is flaccid without nerve connection. Now, is there hope? Yes, for something called nerve budding. So any muscle that de-innervates, that loses its nerve supply, will eventually put out a chemotactic factor, what I like to call a chemical cry for help. And any nerve cells that are around that cell, we don't know the exact distance, maybe it's 5 or 6 millimeters, maybe it's a centimeter, they will bud, and literally a new terminal will create a new connection to that muscle. So that nerve budding takes between 10 to 16 weeks. When the muscle is reconnected, this muscle cell can contract. So how does that show up on the EMG? Well, the EMG, you put a needle into the muscle and you're looking for responses. And the EMG will become more coarse and more thickened because there's fewer nerves servicing the same amount of muscles. So that's why EMGs can be helpful. Also important to note, intact axons have the ability to sprout up to 3 to 4 times. That is, a single nerve can pick up 3 to 4 times the number of muscle cells that it normally serves. So you can bud and you can recover. But the problem we have, hopefully it's on my next slide. We don't know exactly what the injury is. We're not going to go do a surgery, cut the nerve, put it under the microscope and go, this is going to heal in 16 weeks. No, it's not. It's on my slide in the microscope. So we can't go in there and know. So you have to know how the nerves heal, but you can't know what the problem is. So this is the issue. There is no problem, there is no way for the clinician to know which injury has occurred. In the presence of nerve compression with weakness due to a herniated disc or bone spur, the nerve generally needs to be surgically decompressed. So if somebody comes in with miserably red-hot leg pain, but yet they don't have a motor strength deficit, we'll treat them with epidurals, we'll try physical therapy unless they're absolutely miserable. But if they come in with only mild or moderate leg pain, but they have a motor strength deficit, we're going to fix them. Because we don't know how that nerve is going to recover. There are some people who say, I'll take my chances. We generally use the statistics with motor strength deficit. 40% of people will recover without surgery, and 80% will recover with surgery. We're still working on the statistics. We're still writing the paper. That's in general what the story is. And once the nerve is decompressed, the only way to really know about the type of injury is with tincture of time. Is it going to heal or not? Even with surgery, 20% of the patients don't get full recovery. We just don't know. And there's no way at this point to know. So, to recover functional compression injuries, ulnar nerve on the arm, right, will recover immediately up to days to weeks. We'll see patients, we'll do a decompression of the L5-S1 root, and that night their gastroc soleus is 5/5, whereas 4/5 before. So they probably had a functional compression. Myelin sheath injuries, 4 to 12 weeks. Nerve budding, 10 to 16 weeks. Complete nerve injuries take as long as the length of the nerve to the muscle. This is with Wallerian degeneration. And budding is 10 to 16 weeks. If the weakness has not recovered in a year, the functional loss will probably be permanent. Okay, and then finally, tethered cord syndrome. This is a gentleman who just came into the office the other day. Why do I think he has a tethered cord syndrome? Does anybody remember the rule? Here's the bottom, there's the conus right there. Where's the spinal cord supposed to end? I hear a lot of L1. So 5, 4, 3, 2, 1. So the spinal cord should end right about there, and it's way down below L2, 3. So what's happened? Well, physiologically, the spinal cord when you're born sits near your sacrum. And as the vertebral bodies grow, the spinal cord does not elongate and is pulled up into the spine until it normally ends behind the body of L1. But you remember that structure at the very end of the spinal cord, not the nervi erigantes. There's a filamentous structure at the very base of the spinal cord at the conus that can create a tether. Phylum terminal, does it? Oh, I'm seeing some shakes. Okay. So if the phylum terminal for some reason is too strong, the cord will not fully pull all the way up into L1, and this is a tethered cord syndrome. And so unfortunately, this was caught late. I think the man is in his 40s, and he's going to go, I don't do this kind of work, so he's going to go to have somebody release it. But the odds of having great relief are not terrific, but at least it's something to do. So, and then cauda equina syndrome, finally. Cauda equina syndrome, remember the small filamentous set of nerves called nervi erigantes in the cauda equina coming right out of the conus? Do you remember what levels they are? That famous mnemonic? S2, 3, 4. Now, hard to forget now. So, these nerves are more difficult to recover from because they're parasympathetic, they're not somatic nerves. So if you've got a massive herniation compressing the cauda equina, patients will have saddle anesthesia, so really numbness around the buttocks area and perianal region. They'll have loss of bowel and bladder control, and we'll go into a physical exam on how to test that, and it's your requirement to test it if somebody's got it, because you've got about 14 to 20 hours to fix them before it becomes permanent. So this is one of the surgical emergencies. Oh, I guess we'll go into some infectious diseases of the nerves. Of course, Lyme disease is a big one, syphilis, HIV, Guillain-Barré syndrome, polio, and herpes zoster. We'll talk about some of these individually. There's acquired diseases, so subacute combined deficiency of the cord from, does everybody remember what that one's from? B12 deficiency. Beriberi, B1, multiple sclerosis, Lou Gehrig's disease, Parkinson's, and peripheral neuropathy. And inherited diseases, we'll talk about Charcot-Marie Tooth, a little bit about muscular dystrophy, and myasthenia gravis, we've already talked about. So Charcot-Marie Tooth, real quickly, somebody comes into your office, they have foot drop. You look and their feet are cavus, meaning they have big high arches, and they look like they have stork legs, so their calves are not really big. Typically, this is going to be Charcot-Marie Tooth. It causes damage to the peripheral nerves, both sensory and motor. So you can start to rule things in and out. If somebody's got a sensory deficit, that can be radicular, right, nerve root compression, but it can be CMT. But you're going to see patients that have symmetric changes, high arch, drop foot, and stork legs. Multiple sclerosis has to do with the oligodendrocytes. Is it with the Schwann cells? Are Schwann cells affected? I want to see heads nod yes or no. Make a commitment here. No, because this is a central nervous system problem, not a peripheral nervous system. You have loss of the oligodendrocytes, and so you have conduction loss. But since this is central nervous system and not peripheral nervous system, what are the symptoms going to be, or what are the signs? We talked about them earlier. What's that? Clonus, yes. So hyperreflexia, clonus, long tract signs, problems with balance and fine motor skills. That's how you start to think about these things. So, balance and coordination. This is probably the most difficult subject we'll deal with today, and I only have 2 slides on it. So it's a complicated feedback mechanism with proprioception, sensation, and automatic muscle contraction. The cerebellum regulates balance and coordination, so it could be a cerebellar problem. The visual system and the vestibular mechanism contributes to feedback to the cerebellum. So if you have visual problems or vestibular problems, you can have problems here. Feedback through the muscle spindles and Golgi tendon organelles completes the feedback mechanism. So where can you stop that and still have all of these intact? Right here, where you have cervical compression of the cord and myelopathy. So you have to start thinking about this. And the vestibular mechanism acts as a gyroscope to inform the brain of motion. How does that affect vertigo? Can you get vertigo from myelopathy? No. That's going to be feedback problems with balance and fine motor skill. Vertigo is only going to come from the vestibular mechanism. And the cerebellum provides unconscious messages to the trunk and legs to keep the body balanced. So you have to look at all these things. This is not a course in vestibular mechanism and balance, but it gives you an idea of what's going on. So you can have a vestibular mechanism, you can have proprioception problems, again, syphilis, myelopathy, B12 deficiencies. Pain inhibition can give you imbalance. If you have a painful hip and you're already a little off and you try and put weight on it, it can make you fall over. So you have to look for the structures. Maybe they just have a painful hip and their imbalance is from pain inhibition. Do they have functional motor loss? People have come in with a Trendelenburg gait, right, gluteus medius, L5, and they can't stand on their hip. They want to fall over. And that's not because they're imbalanced, it's because they have a deficit. Base of the brain integration, so people can have vertebral artery syndromes, Chiari malformations. We won't talk about cervical things today, but nonetheless, strokes, Wallenberg syndrome, vertebral artery loss. They can have cord malfunctions such as myelopathy and MS. They can have optic writing reflex loss from MS and stroke and joint disorders. That's enough for balance. Okay, Charcot joints. This you'll find in paralytics typically. People have lost every proprioceptive mechanism, and for some reason, the joints without proprioception break down and just become awful. They do have painful backs even though they're paralyzed and they have no sensation from the waist down. We think there's an autonomic or a parasympathetic sympathetic connection to the somatic nervous system that causes this. And then conus injuries, as we talked about here, can lead to bowel and bladder dysfunction with a normal lower extremity function. So if you injure the conus, well, this spine is terrible, but let's say he had a normal spine except for herniation at L1-2, they can come in with bowel and bladder problems and yet have a normal neurologic exam except for you have to test the bowel and bladder, right? We'll talk about how you do that. Okay, I think that's enough. I haven't made anybody fall asleep yet, so let's take a break.